All right. So welcome everyone. Thank you for joining us today for this panel discussion. We're very excited and grateful to have you all here. We're going to be having a panel today on applying AI to improve public health outcomes. And we have a great set of elite panelists to share their views on using AI for public health. Okay, I'll introduce myself first. I am Aparna. I work in the Google Research India lab in the social good team with Professor Milind Tambe. And yeah, I'll start by introducing our panel here. First of all, we are very grateful to have Dr. Aparna Hegde. She's the founder, chairperson, and managing trustee of ARMMAN. ARMMAN is an India-based non-profit organization committed to improving the well-being of pregnant women, new mothers, infants, and children in the first 5 years of their life. They design and implement sustainable interventions to reduce maternal, neonatal, and child mortality and morbidity in underprivileged urban and rural communities in India. Dr. Hegde holds a master's degree from Stanford, and she was awarded the IUGA International Fellowship in Urogynecology and Pelvic Reconstructive Surgery. She's the associate professor of urogynecology and head of upcoming urogynecology department at Kama Hospital in Mumbai. She has received many prestigious awards. Among those are the Skoll Award for Social Entrepreneurship in 2020, TED Fellowship in 2020, and she has also been listed by Fortune as one of the world's 50 greatest leaders. So, thank you so much for joining us, Dr. Aparna Hegde. We're really grateful to have you here. Next, we have Dr. Maya Majumdar. She's a computational epidemiologist specializing in emerging epidemics and a recent graduate from MIT. Before this, she was a postdoctoral fellow at Harvard Medical School's Healthcare Policy Department. Her current research focuses on probabilistic modeling, artificial intelligence, and systemics epidemiology in the context of public health, with a focus on causal inference for infectious diseases surveillance using digital disease data. As of January 2019, Dr. Maya has been engaging in pandemic response efforts and is a leading expert in COVID-19 epidemiology. Thank you for joining us, Dr. Maya. Next, we have Professor Madhav Marathe, who is an endowed distinguished professor in biocomplexity and director of the Network System Science and Advanced Computing Division in Biocomplexity Institute and Initiative, and he's a tenured professor of computer science at the University of Virginia. During his 25-year professional career, he has established and led a number of large transdisciplinary projects and groups. His areas of expertise include network science, AI, high-performance computing, computational epidemiology, biological and socially coupled systems, and he has published more than 350 articles in peer-reviewed journals and conferences. He obtained his PhD from the University of Albany, and he holds adjunct appointments at Chalmers University and the Indian Institute of Public Health. Thank you for joining us, Professor Marathe.
Thank you.
And last but not the least, we have Professor Milind Tambe, who is the Gordon McKay Professor of Computer Science and Director of Center for Research in Computation and Society at Harvard. And he's also actually, also Professor Maya is a professor at Harvard. Sorry, I forgot to mention that. Professor Tambe is also the director for the AI for Social Good team at Google Research in India. His work focuses on advancing AI and multi-agent systems for public health, conservation, and public safety, with a track record of building pioneering AI systems for social impact. He got his PhD from CMU. He has received several awards at conferences, top AI conferences. Some of these include the HKI John McCarthy Award, the ACM Autonomous Agents Research Award, AAAI Robert S. Engelmore Memorial Lecture Award, amongst a few, to name a few. His work on AI and multi-agent systems has often provided the first very uses of key multi-agent system models and algorithms in the real world across key sectors like public health, conservation, and public safety. Thank you, Professor Tambe, and over to you now to introduce this event while we're here.
First of all, I thank you for that very nice introduction, Aparna. And I'm so honored to be here with these very distinguished co-panelists. I'm very fortunate to have been collaborating with all of them. I've been honored to have been co-authoring papers with them as well. So the occasion of this panel is that in 2020, we launched a set of 6 AI for social good projects out of Google Research India. This was a pilot for the next set of 30 projects that we launched in 2021. One of those projects was a collaboration with ARMMAN, Google Research India, and IIT Madras. This is now mature to the point that software is now being handed over to ARMMAN for their use in daily activities. So to mark this occasion, we have this panel this panel discussion to understand with these distinguished panelists and experts, what are some challenges and pitfalls of applying AI in public health? What should we look out for in the future? What to monitor? How do we effectively evaluate these systems of AI for public health? And this is particularly valuable because, as I mentioned, not only did we have those 6 projects that we launched in 2020, but there are these 30 new projects that got launched in 2021. And I know several of you in the audience are participating in these projects. So hopefully this will also help us discuss what's the road ahead. As we all know, AI for social good is still an emerging discipline, and understanding what guidelines to use and so forth is really important. So let me set the stage for what we accomplished in this collaboration with ARMMAN. So ARMMAN has this program called mMitra, and I'm sure Dr. Hegde will speak more about it. It has reached up to 2.5 million women and children. And essentially, it's an education program that provides through 141 calls information to expecting and new mothers about health of the baby and the mother. Whereas mMitra has proven that it leads to significant improvement in maternal and child health. One challenge ARMMAN pointed out to us was that 25 to 30% of the women may become low listeners over time. And the question was, can we improve adherence in the program using AI-based interventions? Specifically, if we could make live calls to a small fraction of women, which women should it be? Could we predict in advance who are the high-risk women on a weekly basis and prioritize who to intervene on so that they are retained in the program? So this was accomplished by the first use, as far as I know, of restless bandits on a large scale. So this is the AI technique being used, which is restless bandits on a large scale. So we have done a trial, a pilot test with 20,000 beneficiaries who participated, and shown that this restless bandit technique leads to a significant improvement. There's a paper that's available at the link. Your comments are very welcome. It is going to get submitted to AAAI. It'll also be available on archive very soon. So this is just one example of a system that is being deployed. But with that, I'm going to hand this over to Aparna Taneja for further questions to the panel on what lessons do we draw from what has been done, what to watch out for, and so on. Over to you, Aparna.
Thank you, Malin. So without wasting any more time, first of all, we'd love to hear your thoughts on what are the challenges in public health where AI could play a pivotal role. Dr. Hegde, if you could start.
Yeah. So in public health, especially the kind of programs ARMMAN does, right? We work with large amounts of data, right? So we are talking about programs that are in 18 states. Through Kilkari program, we're reaching around 25 million, and through mMitra, 2.3 million. So there are, AI is very, right for programs such as ours, where we can use AI to predict, for mMitra program, low listeners, right? We can also understand how, the right kind of content can be created for the right kind of, subscribers. It will be very easy for us to understand using AI, how to improve, the health worker training programs that we have, the effectiveness and efficacy of those, right? Going forward, because we work in the field of, predicting risk factors, right? So, I mean, the whole, our programs are tailored towards picking up risk factors early in pregnant women, children, and kind of tracking them, right? So if we can use AI and do machine learning to eventually be able to predict risk factors, right? So you imagine what can happen. We can be able to create solutions that are targeted for particular women, because we can be doing secondary prevention, right? So you're able to use the data over years to predict which woman will get which risk factor. We'll be able to then tailor content towards that women to help in secondary prevention. So it's almost like personalized medicine, right, going forward, and even population-based, right? So if we can use AI on, like when we work with, large-scale data of, the whole state, you're able to even hopefully in the future predict which part of the state is going to have which problem, and we can anticipate it and actually tailor our resources towards that, So AI, I mean, we found to be very useful in these aspects of our work. And the only thing I want to say here is that you should actually know where to apply AI, I mean, if you ask the right questions, it really proves useful. So for us, it was about improving the effectiveness and efficacy of our program implementation. And that's where it really fit in very well.
It sounds wonderful. Professor Maya, would you like to add something to this?
Yeah, sure. So I'm obviously based in the US, and one of the things that we've been dealing with universally in the midst of the COVID-19 pandemic, especially in more recent months, are ways to surveil misinformation. So I think that this is something probably all of us on the phone are very, very familiar with at this point. It's a universal problem, health-related misinformation. It has existed long before the pandemic. It will persist long after the pandemic. Here in the US, we have a very long history of anti-vaccine sentiment, and that's been particularly challenging right now as we are trying to deploy vaccines across the US. And one of the things that we are trying to do in my team is we're trying to leverage data sources like social media and search query data to try to understand where different alcoves of misinformation exist geographically, not only in the US, but around the world, and what seems to be motivating those misinformation events in terms of their propagation. So something that some of you may have seen recently is that here in the US, we are dealing with a very unusual problem the last couple of weeks, where we have folks, especially in heavy farming states, who are taking ivermectin, that is a drug that is prescribed for farm animals to help prevent COVID-19. And so this is a very current and very ongoing problem that we're dealing with in the US, but there have been predecessors. In April 2020, we had something similar that happened with bleach, where we had folks who were drinking and injecting bleach because of something that our then president had said in terms of bleach being something that could be used to prevent COVID-19. So we clearly have a problem here in the US. I mean, there are some very unique problems that exist in the US that make it very prime for misinformation research. But in general, artificial intelligence has opened a lot of doors for us in terms of understanding these phenomena better. So not only in terms of opening up new data sources that we can use to actually track and surveil misinformation and how it spreads, but also, and perhaps more importantly, now we can start to think about, well, how do we intervene, right? So when we know that there's a misinformation event that's occurring, and that there are certain people who are very susceptible to it, either because of where they live or because of their other demographics, what can we do to intervene in that population so they don't make mistakes that can harm their own health or their loved one's health? And so this is where identification of trusted influencers becomes a really interesting problem. And it's something that exists kind of at the intersection of social network analysis and machine learning. And it's something that we're dealing with right now, trying to identify who are the most influential nodes in a network who can get out better information when you have a misinformation event that's occurring. And I think that, sometimes we think these are going to be really famous people who are, they have tons and tons of followers on social media or what have you. But what we're increasingly starting to find is that more often than not, it tends to be people who are very well connected in their individual networks. And these are people who are trusted because of other roles they play in their network. So here in the US, we have things called parent-teacher associations at school districts. And one of the things that we've seen is that the PTA council members will have more influence even in social networks that are online than we might expect, say, a very famous internet star to have. And so this is something that we're really interested in understanding better. And a lot of this ends up having to do with the scale of the network that we're looking at. And I think that this is an area where I'm personally very interested to see what additional contributions AI can make in terms of tackling health-related misinformation, not only in terms of surveilling and monitoring it, but intervening upon it and helping people make better decisions for their health.
It's very interesting. Thank you. Professor Marathi, would you like to add to this?
Sure. So I first want to just start by thanking Milind and you all for undertaking an amazing set of projects. I was not aware of the magnitude of the work that Milind and the team has done in such a short time. So kudos to you all. I also want to congratulate Aparna Hegde for an amazing project, and I hope I can work with you and help you in any ways I can, because in the end, the theme of AI for social good, the social good is really important. One can use any method one wants, but in the end, it has to help the community. So with that, let me say a little bit about ways we could use AI in problems related to public health. My personal work has been in the context of pandemics, and like Maya and Milind, I have been working on responding to COVID-19 pandemic for a long time. But we also responded to the Ebola pandemic, which happened in 2014 and 15. And Maya actually was working with us then as well. And the reason I bring it up is that these pandemics are not going to go away. We're going to get another one sometime later. They're all examples of how infectious disease essentially consume large parts of the world. This one, of course, is the mother of all of them. At least since 1918, we haven't seen anything like this. So as examples of ways where one could use AI-style technologies in this, and one thing I would like to clarify for the audience, because of the usage of terms, and as a computer scientist, I feel almost obligated to do that, is the word AI has become synonymous with deep learning, and I strongly reject that. I think AI is much richer, much bigger than deep learning, although deep learning has a huge role in it too. And I also think that AI is becoming equal to computer science or computing technology, and that's also not the best way to do it. I think there are really interesting technical ideas that are at the intersection of many, many different fields that we are after in applying. And Milind gave a nice example of Restless Bandit, and Maya gave an example. So we use multi-agent simulations to support pandemic response here, Aparna. We've been working very closely with the Department of Defense. We've also worked very closely with Virginia Department of Health. We are, in fact, the lead modeling group for them. We work with the CDC here and have supported them. But in terms of the kinds of things we have put it to use, Maya actually provide a very nice example on misinformation. We have done that. And let me give you just two more examples from this, where we have actually worked with our colleagues at Google to understand the role of mobility in terms of controlling the pandemic. We saw that mobility played an important role. It continues to play, but it's very nuanced right now. In early part of the pandemic, while it had a large effect, things have changed a little bit because of behavioral adaptation. So building AI techniques that combine this, I think, is an important topical area. Another topic that we have worked on that probably is worth mentioning is the recent work that we did with Yuri Leskovic and his colleagues, Serena Chang, at Stanford, on building a decision support tool based, again, on mobility data from SafeGraph to try and understand what impact would one have if you were to partially close or reduce the social interactions in these places. And as a final example from pandemic, we just have put out a report on vaccine allocation. Turns out to be a very important, interesting question, has been going on for a long time. We think that there's a way to use social network theory to identify I would call central nodes, much like the influencers that Milind talked about, to do this well. And I think it's really important to potentially consider this, especially in places like India or other developing countries where we don't have enough vaccines. And while it, of course, challenges us in terms of ethical issues, in terms of misuse of it, I think in the end, if you have a very limited quota of vaccine, which is likely to be the case for the next few years, we should consider techniques that allow us to study that. And I'll talk a little bit more upon as I go along. I don't want to take all the time. Thank you.
Thank you, Professor Marathi. Milind, would you like to add something to this?
I think a lot has been said about use of AI for public health. I wanted to speak more about the AI techniques that can be brought to bear. And I wanted to concur strongly with Madhav that that there's a lot more in terms of AI techniques other than deep learning that can be brought to bear, although obviously that plays a massive role. So some of the things that we've done going along with the theme of identifying influencers in social networks are for use of social network influencers for HIV prevention. And so this is work where we did with a homeless youth community in Los Angeles, where harnessing the social networks of these youth, we're able to show that our influence maximization algorithms can identify nodes far more effectively compared to traditional approaches. And via a trial with 800 youth are able to show that they're actually significantly better in terms of reducing HIV risk behaviors. But besides use of social networks, there are bandit algorithms, there are, Madhav talked about multi-agent simulations as well. And so we have to understand, as we think about these interdisciplinary approaches, and Maya has been a very strong advocate of interdisciplinary work, as I've followed her on Twitter and so on and so forth, that we have to understand that we start from the problem at hand in public health, understand from the experts what exactly is the need of the hour in terms of the kind of AI technique that would be most valuable, and from there understand the kinds of approaches that can be applied. So in this particular case, understanding the problem of ARMMAN and mMitra, the technique that appeared most relevant was one of restless bandits, but in other cases it may be social networks. In yet other cases, other kinds of multi-agent simulations or other techniques may be applied. Here we have to understand in AI for social good that we really want to achieve impact, as has been stated earlier on the panel, and therefore going all the way from understanding what kinds of data are available all the way to deployment and evaluation. All of these steps are crucial, and all of that is part of AI for social good. And it's not just the advance in AI algorithms that are important. Those are obviously our bread and butter, but the rest of it is really important, and that can only be achieved via an interdisciplinary collaboration. Back to you, Aparna.
Extremely well put. I mean, it's really truly intersectional, where we have a variety of approaches from, like you said, not just deep learning, but a variety of approaches from AI. And equally important is understanding the community where we're trying to deploy this solution, because like Maya gave a wonderful example, Aparna gave a wonderful example, it really changes from community to community, and you really need the domain expertise and the context to understand what would really work well there. Next, I'd like to ask your thoughts on how can we effectively evaluate AI-based interventions in public health. Professor Marathi, could we start with you?
Yeah, I think it's a very nice question and a tough question in many ways. The reason being that, of course, the standard measures of looking at downstream impact, for instance, improving health and such, could be used as metrics. But how do you try and essentially disentangle the particular value one has added from these techniques versus things that have happened otherwise on the ground remains, I think, a challenge in some ways. So let me put just one hard example on the table as a question rather than answering your question, but I think it'll capture a very interesting problem that we face here. So our group, and I think Maya, I think does it too, we participate with the CDC Forecasting Hub, where we try and forecast the dynamics of COVID-19 for the next 4 weeks. So every week, like today, we would tell them what the numbers would be week after today, 2 weeks after today, 3 weeks, and 4 weeks. And we do this, and I think something somewhat unique for our group is we do this for all 3,000 counties in the US. Now, we also have started doing this working with the European CDC to provide a similar data set for Europe, and we just are starting to unveil a similar tool for the Indian context, which I think, and I'm hoping it can be used, and I would need Milin's help, hopefully, to popularize it there, working with IISc in this particular context. But here's the question. If I forecast that the numbers would be, a certain number, let's say 10,000 cases for the next week, and the number turns out to be 2,000, would I say that my forecast was wrong? Or would I say my forecast actually changed individual behaviors, and 1 week is not the right number because, of course, the behavioral change will not show up. But let's say 2 or 3 weeks from now, is the forecast wrong, or is the behavioral adaptation that forecast caused the numbers to go down? So evaluation of how good your forecast is a non-trivial question in any co-evolving social system. Economics is the same way. So economists are, of course, very smart. They've declared an efficient market hypothesis, and they've claimed that you can never forecast the market exactly and gotten away. But my point is that social systems forecasting, which is a central portion of all of these infectious disease outbreak questions, is deeply joined and endogenous to the system itself, which means it changes the system's path. And so this is one example where I think evaluating the methods is non-trivial. And another method, for instance, that I would like to bring up is impact of interventions. So people have argued contact tracing is very helpful, vaccination has reduced, but perhaps again we do not know exactly the overall impact of contact tracing in the system, and this has been an ongoing debate. It is intuitively clear it helps. We know in short scales it does help, but confound itself with so many other factors that I think it becomes challenging. So one particular method that we have developed recently, and I'll leave it there after that others can say a little bit more, is we have developed this idea of a digital twin where we represent the population essentially in great statistical detail inside the computer. And the reason to do that is then you can carry out randomized controlled trials effectively in this simulated population. So to the extent your simulated populations, your interventions make sense and the behaviors are captured at some level of correctness, the trials that you can do in the simulations provide you with one potential way of evaluating the efficacy of this. I think this is a really nice area to pursue further. I know that these trials have had big impact in India, has led to the Nobel Prize in Economics 2 years back. But I think that there's a huge interesting way to do these trials within the digital world and using it to understand the efficacy of these systems. So I'll stop there, Aparna, in the interest of time.
That is wonderful. Professor Maya, would you like to share your thoughts as well?
Yeah, so kind of going off of what Madhav just said, there's this saying that we have here in public health schools, and it goes something like this: when public health measures work, nothing happens. And so what this means is that when our public health systems are doing their job, there is nothing newsworthy to report. So one of the things that's a very good example of this is here in the US, we are very lucky to have very strong water and sanitation systems across most of the US, not everywhere. There are many places in the US where this is not the case. But in a lot of other places, we have good water and sanitation. Like here in Boston, it's pretty good. You can drink water from the tap and not worry about it. And as a result, there are no newsworthy cholera outbreaks that are happening here in Boston. And so this is something that I like to think about a lot for a lot of the reasons that Madhav just outlined, because when our interventions work, then what you end up having are fewer cases, fewer deaths, fewer infections, and that's not necessarily something that gets picked up by the news as something that's newsworthy. That's not something that the public will generally see as something worth celebrating. It's something that we tend to take for granted to some degree, and I think that it does complicate how we evaluate the efficacy of different interventions because of exactly what Madhav said in terms of the behavioral components that impact all of these things, whether it be infections or cases or deaths. The behaviors that we choose to partake in as individuals certainly influence the population level measures that we see during any infectious disease outbreak. So this is definitely something that is a major challenge. And it's a challenge that has these social and societal aspects associated with it as well, because of the tendency, at least in high income countries, to take public health for granted. And so I think that this is something that I personally have been thinking about a lot just from a philosophical point of view, because it does complicate these ideas of evaluating the interventions that we attempt in a lot of ways. That said, I think that one thing that Madhav also brought up that I want to kind of focus on briefly is that, you know, AI interventions are one subset of many other interventions. Contact tracing is one of the areas where we have AI-enabled contact tracing, which is something that Milind and I have worked on a bit with one of his postdocs. But we also have more traditional contact tracing tools that have existed for hundreds and hundreds, arguably thousands of years. And so I think that sometimes, you know, making sure that we're acknowledging the fact that there are all these interventions that are not AI enabled is really important as well, because I would still say that in public health, most interventions are not AI enabled. Many of them are policy enabled. And this brings me to the next thing that I want to say. So I think that one of the things that AI can do, and I think this is something that I have personally been very interested in as a health policy scholar, is evaluate the way that different policies have impacted different metrics retrospectively. And so this is something that my group is working on right now. One of the areas that we are pursuing this in methodologically is automated discontinuity analyses in different time series to try to understand the way that policies that have a very sharp beginning and end point may be impacting different metrics that we care about. And I think that this is one of the ways where this isn't an AI intervention, but it's AI being used to evaluate an intervention that is policy-based. And I think that that's an area that I'm personally very excited about. The pandemic has yielded a lot of opportunities for this, for better or for worse, partially because here in the US, at least, we have a federalist system in that every state kind of has its own government that does its own thing. And as a result, we have lots of different policies to evaluate and try to understand, especially in the vaccine allocation context, which of these perhaps worked better than others. And there have been a number of different policies that have been enacted here in the US. I will ramble some of them off. They include things like making people eligible for different types of lotteries. They include things like giving $100 to every person who gets a shot. They include things like being able to bring somebody else along when you get vaccinated that you care about so they can also be eligible. And now what my team is trying to do is trying to understand across all of these different policies, which of these actually increased uptake of vaccination the most, and perhaps more importantly, which can be generalized to other locations where there are dose insufficiencies. And that would include places like India, Bangladesh, Pakistan, most of South Asia, most of the African continent. So I think that's an area that I'm personally very excited about, which is not quite the answer I'm sure that Aparna was looking for, but I hope interesting nonetheless.
No, it is definitely. And if we can have something generalizable, which is, you know, not just certain location dependent, then it's even better. Dr. Hegde, you face this on a daily basis in the real world. So what do you think?
So your question was on how to measure the effectiveness of AI applications, right? No, I think it depends on the question you're trying to ask, and it depends upon the organization approaching, you know, professors like you yourself, like Dr. Milind Kambe, to answer, right? So I tell you, I'll give the context of the program that they worked on, right? So the So we do a program called mMitra and also Kilkari, which is almost in 18 states, where we send voice calls. So that came from my experiences during residency, where I really saw very closely how, you've got really overcrowded clinics and there are 200 patients waiting outside in the antenatal clinic, and you just have a minute with them and you don't counsel them, right? And they never come back, hours and hours of waiting, they never come back to you, and they come back dying, or the child comes back malnourished, right? So I kept seeing this over and over again. So we started this program called mMitra, right? So now almost everybody has a mobile phone. So why not reach across to women directly with with voice calls, targeted voice calls, timed and targeted through pregnancy and infancy. So we handhold them. Now we've already proved that it works, right? So mMitra started off as an RCT, which showed impact, right? So in almost all metrics, we look at knowledge recall, right, about the information, behavioral change, and health outcome. We've already shown impact of mMitra before we approached Dr. Tambe to say that now, please come and help us improve listenership. What we were facing was that, there are various reasons women may not listen, right? Or they may not pick up, and if they picked up, they may not listen for that long. Now, how do you understand who's listening and why they're not listening? Why somebody not listening, and how can we get them back in the system? Because we already proved if they come back to the system, their health outcomes improve, right? So that's when we came to Dr. Tambe, and then you created the model, and and we've done iteratively this whole process of understanding how this works, right? So initially we did a small study of creating the model, proving the model based upon the data already existing, and then we went ahead and kind of looked at, if we pick up women who are potentially going to be low listeners, if we call them or we send them SMSs, are they going to come back to the system? And in that small trial, we realized that, if you call the women, they'll come back, right? And then we went on the next step, right? Decentralized calling. So we enroll women through hospital supervisors, right? Our women's health workers sitting in the hospitals who enroll women when they come for their first visit. And we also enroll through NGO partners. So we started doing decentralized calling, right? So, the model would pick up low listeners, and then we would have hospital supervisors and the health workers on the ground calling the women in their area. So the number of calls to be made were much lesser, right? So when we did that, 70%, there was a 70% improvement in call success rate, right? So we could reach about 70% of the calls were positive, right? So, and what did we find, right? So the more we reach out, the more we realize why they're not listening. So, 2% had lost their baby or had an abortion, right? 5% want to change the language. 15%, want to change the time slot. So we give them a time slot choice, when they can receive a call, right? So 15% wanted to change this time slot because they had a shared phone and they didn't know that time slot they'd given didn't work for them, right? And so on. So, and 8% wanted to actually drop out of this, program. So when we found out that, and then we prioritized, right? So, and the good thing about this new model is that it not only helps us understand and pick up the low listeners, it also helps us optimize whom we're going to call, right? So what is going to happen is that iteratively it's going to get better, how we pick the right, low listeners and get them back in the system. So now the thing is that the latest study has shown, you already know this, 23,000 women, we did this, the sample is 23,000 women, because we work so many women, the data sample is also huge, right? So in 23,000 women, we proved that it leads to 28% increase in listenership, right? So we're seeing that. So now we're coming to a point where now we already proved impacts earlier at mMitra. So obviously when you have more listening, women who are listening, their health outcomes are going to improve. But we're going to go on to a study now where we're actually going to do a study where we're going to enroll women into an RCT, and one group will have the model working, the other group will not have a model working, and then we're going to look at the end of pregnancy and look at their health outcomes. Now our study is amenable to a study. Our program is amenable to a study. We can easily go and look at the health outcomes of the women who, were helped by the model. So that's what our next step, right? So we already know it works. And obviously we're going to go and do a proper study to show that, the health outcome also improves. So for us, I think from the impact perspective, I think it's the questions you're asking, right? If you ask the right question and you know where you're applying the model, you may be able to kind of look at the, health outcome.
That's wonderfully put. Milind, would you like to add to this?
So let me speak very quickly and speak to another aspect of this question of evaluation, which may be important to the students who are here from the AI side, as well as some of the nonprofits who are here, who are collaborating with the AI researchers, and to understand their impatience in doing this work. And that is because these evaluations, as Dr. Hegde has talked about, or Madhav and Maya have talked about, are long time horizon evaluations. it takes a very long time to start a trial, do evaluations, so forth. Going back to the HIV prevention work I mentioned in Los Angeles, we started that in 2014 with an idea, and then, you know, from small pilots to all the way to understanding behavior changes. The last paper appeared in 2021. So it was a 7-year process in order to actually complete all of that work. So if we are thinking about work in AI for social impact, we have to understand that this is different from the kind of AI work that many of us have been used to, where it's an algorithmic improvement, there's a ready data set, you show you're better than a benchmark, this study can be done in 3 months, you can publish a paper and be done. This is not, in AI for social good, you really have to involve yourself in the community. And in order to show impact, it has to be a long scale study. There may be some proxy measures, but those ultimately wouldn't be totally satisfactory in terms of showing actual impact. So we're very grateful that we have done this work with Aparna Hegde, and you know, it's been going on. But as you can see, it's just taking a while to get these evaluations in place. So what should students do, and you know, what can we do as a field? So I wanted to just list out a few things. First, a shout out to the AI for Social Impact track at AAAI for people who are working in this area, because that's a track where you can just write a paper about evaluation and not worry about necessarily improving methods, because AI conferences are obsessed with trying to improve methods, even if they aren't really useful for the particular application. Whereas we really want to emphasize that there's actual impact on the ground. So that means we also need more venues, because ultimately people will change their behavior based on the reward system. And if the academic reward system is entirely focused on improving algorithms, then that's what we will get. And so if we really want to achieve AI for social impact, we need new venues for publication. So I encourage people who are in this audience, who are thinking about new venues, new journals, new conferences, to make sure to encourage some of those to happen. The second is training. You know, as computer scientists, we are trained in some types of evaluation that are suitable for algorithmic improvements, but not to the kinds of public health evaluation. And so this requires us to come up with newer training programs, newer courses, where these kinds of evaluations are really core in training our students. And so I'll stop there. There's also scope for more textbooks in AI for social impact that go beyond the standard AI textbooks and really include some of these ideas from public health and from social work and other disciplines, in order to understand how do you actually do deployments, how do you do deployments at scale, how do you measure actual improvements, and so forth. In the interest of time, I'll stop there, but hopefully these are ideas that may be useful for students. And mostly, don't lose heart if you think that your evaluation is taking time and publications are taking time. These are important things that we are doing in AI for social good, and patience is important. Thank you.
Aparna, can I add one last thing before we close out this question? So one thing that's been brought up by all of my esteemed panelists that I want to mention here are, you know, the importance of RCTs. I think that one thing that is undeniable is that we do need randomized control trials for evaluation of a lot of different types of interventions. But I do also want to remind the audience that they're not the only way that we evaluate interventions in public health. And in fact, some of the most valuable observational studies that exist have saved millions and millions of lives. The most common one that I like to cite is the fact that we never did an RCT to figure out that smoking gives people lung cancer, but somehow we know that. Right. And I think that this is a really important thing that I really want to emphasize, especially for our CS students who are on the line, because I do want to say, you know, sometimes it's unethical to randomize people to, say, smoking or non-smoking when you know that smoking has these carcinogenic effects. And that's also true for a lot of the interventions that we study now. And so as a result, one of the areas where AI and machine learning especially are able to make big strides are as we accumulate more data, not just health data in the form of electronic health records or what have you, but also social media data and other sorts of data points for every person that exists on this planet, we're able to do stronger observational research. So if I were to make a pitch for any one area for folks who maybe don't want to study RCTs but are interested in social good research, it's learning how to make observational studies stronger. I think that's an area where there is so much left to do, and we have a really strong precedent in public health for some of these impacts to be really broad, and smoking and lung cancer are just one example of that.
I agree.
Thank you, Professor Maya. Actually, this brings us to our next question nicely. What are some challenges and pitfalls to expect in deploying the AI-based interventions, and also potentially some warning signs to monitor for when conducting such interventions? Dr. Hegde, would you like to start? This would be our last question, and hopefully if you have time left, then we can potentially get some questions from the audience. So Dr. Hegde, would you like to start?
Challenges. I think it depends on the question you ask. You should really know what question to ask, and and whether AI can really work in that area, right? And I think a lot of the problems arise where you do not really, understand whether AI is the right fit, and oftentimes data analytics that gets passed off as AI, right? So it's very important that you understand the right question and ask them, and that's what we kind of work with your team on, right? Asking the right questions, because otherwise, I'm going to keep it really short. For me personally, that's the main point, right? What question have you asked? And secondly, also knowing that AI is not a panacea for everything. It's almost become like a buzzword, right? Everywhere, it's almost as if we have AI now. Where do I apply it? It's not like that, right? And that's the big challenge that I see. It's like the Bitcoin thing, right? I hear it everywhere. So AI here everywhere, right? So you have to be very careful about that, right? It should never be top down, right? And that's what is the problem, right? So I think when Dr. Tambe's team, Dr. Tambe and I met, we were at a point where we had these questions to ask, and so we got there is a right fit there, right? And just because Dr. Tambe, I got the acquaintance of him, we were trying to look for things to solve in our programs, and try to fit it in. It would have been a waste of time for everybody, right? So that's the whole point, right? So find the right question, see whether it's a workable problem. Also understand whether this can be measurable, because I'm telling you honestly that in public health, and that's one of the biggest things, even when I founded ARMMAN, right, is that even our own solutions, measurable, because impact measurement, as Dr. Mazumdar has clearly laid out, right, there are various ways of doing it. I completely agree. It doesn't have to be in RCT, but you need to show impact, right, because before you create scalable solutions. So it's so important to understand whether, yes, it's difficult to measure outcomes, but there are certain areas where you can. And I mean, I understand all the problems talked about in forecasting, etc. But at least, you do know before you scale up that this is something that's worth doing and scaling up, and not just because you have found this great algorithm to apply somewhere.
That is absolutely true, especially, and this holds true for all social good applications, not just public health. It has to be the right amalgamation. Professor Bharati, would you like to add something to this? Any challenges, what challenges we expect, and also any warning signs to look out for when applying AI?
Sure, I'll try to be brief. I think we were probably going to talk about later, but fairness, equity, and ethics are big challenges. Everybody knows about it. The second challenge is really data. It might seem that we have a lot of data, and we have lots in one way, and we have very little in other ways. And I think my panelist colleagues would agree with that. We just don't have enough data in many cases. The third part, and I think Aparna Hegde has really articulated well, in the end, these are enablers. I think we would be doing a disservice to boots on the ground, epidemiologists and social workers who go out and do stuff. Computer programs are really a very small fraction of the final impact that can be felt. If you keep on building these solutions, but nobody does the work on the ground, it has no impact in the end. And in that sense, we have seen Ubers, we have seen all sorts of gig economies coming through. Yes, all those things are cool, but somebody has to do the work at the bottom. Building these programs are only, in my opinion, enablers of these folks. So I really applaud Aparna, and Nalini said she works on diabetes. Folks who are on the ground are really the crucial part. And what we should always remember is the technology should enable them rather than being the sort of main character of the show. So I'll stop there in the interest of time.
That is an extremely wonderful thought. Thank you for that, Professor Marathi. Professor Maya, would you like to quickly add something to this?
Yeah, I'll say something because I think my background here is in many ways at the intersection of my three co-panelists. So before I went to MIT, I did a degree in public health and epidemiology and biostatistics, and I spent many years in a field hospital in Bangladesh at the ICDDRB, which many of you probably know and are familiar with. And my comment about cholera earlier may have revealed my interest in all the work that they do. And I think that one of the things that I've learned and that I would really encourage, especially folks who are still trainees and are on the phone right now to do is, if you're very interested in a particular domain and you also have computer science skills that you want to bring to the fore, there really is nothing like actually going out there and getting your hands dirty. I think that that was maybe the single most beneficial aspect of my entire career, was spending those 5 years, months at a time in Bangladesh on the ground with my colleagues and really talking with patients, understanding their stories, and then thinking about what are some of the ways that we can translate their stories into data. And so this really gets to Madhav's point, where it's really about enabling the work that's already happening. And I think that sometimes if you don't actually go in there and see what's happening, it can create a lot of disjointed thoughts about what should be the next approach for AI or for machine learning or for computer science more broadly. And I think that that's one thing that, when you're still a trainee, that's something that you can do. You are still in the point of your career where you can go out and take some time and actually learn from the people who know best. And the people who know best are almost always going to be the healthcare workers who are working with the patients. And so it's for that reason that, one of my affiliations is at a hospital here in Boston. And that was really important for me when I was pursuing my career, trying to decide where will I go in terms of becoming a faculty. And I knew that I wanted to do artificial intelligence research, but I also wanted to make sure that I didn't lose the healthcare background and experience that I had. And so I think in many ways, this is the future of AI for social good, where we have these kind of strongly interdisciplinary new researchers who have training and background in both things that they care about, their methods and their domain. And I think that ideally, I would like to see that happen across all of these applications for social good. And I think it is starting to happen. And I want to just emphasize again for trainees that, it's not impossible. You can do both. If you care about both, you should do both. And there are going to be advisors who will trust you and believe in you and want you to pursue both. So that's the last thing that I wanted to say.
Yeah, that's wonderful. And yeah, unfortunately, we would love to have that experience too. Unfortunately, due to COVID, these things have been limited to some extent. And to this point, we're really grateful to Dr. Hegde and her entire team at ARMMAN for giving us such wonderful guidance throughout and, honest, real feedback throughout this journey. We really rely on your expertise. And similarly to all the other NGOs with whom we're involved, we have very few minutes left. If there is a lot in questions, maybe you can take one.
Aparna, if I could just say a couple of things, and I think I would speak on behalf of Maya and others as well. So first of all, again, thank you to you folks for organizing this, Milind and others. But what I want to say is that our group is very interested and happy to help in any way we can. In the end, science is all good and fun, but I think this idea of using it for public health, if we don't eventually use it for public health, I think we have failed in our ability to do science. So we are here. I'm hoping that we can reach out to many of you. Aparna, of course, Nalini has posted a few things, but please reach out to us whenever we can. We will be very happy to help. And as Milind says, I think there is enough momentum in the field that people can actually do meaningful science and help. And you couldn't get a better both worlds in some ways to fulfill. So I just want to point out, I really think that this is a great track that you folks have started, and I wish you all the very best with this.
Please go ahead.
Yeah, I just want to say this here, that it's a milestone in our journey. to actually have a model that has been proved to work. I mean, to have 28% increase in listenership. Can you imagine 28% is a significant number? And that we have a model now that we can deploy at scale. And if you can take it through Kilkari, you know, we work in 18 states now, 24 million women. If it's going to go through the country, can you imagine if this kind of model applied at scale? And then going forward, you know, having a lot of data, we can actually, you know, be able to do risk prediction and prevention, because we can really, you know, and the whole personalized thing to a particular woman, right? Predict her risk factors and create targeted content for that risk factor that we can send to her, you know. I mean, and if a state can actually kind of, you know, be able to kind of, you know, predict which particular part of the state is going to have which problem, and, you know, create targeted resources for that particular, you know, part for that particular condition, and etc. Right? Imagine, you know, sky's the limit of the kind of work that can get done with, you know, and to even understand. And for us, you know, especially, I mean, we come from the non-AI world, to know where it all started, right? The link between Russian submarines. I think you've not mentioned it. I mean, your whole group knows it, but for us to know that the restless bandit algorithm was something that was used for, you know, Russian submarines, right? I mean, to find what was the whole story behind it, Dr. Tambe?
Yeah, so I guess the paper referenced one of the applications. The first paper on restless bandits was trying to see Russian submarines from the sky, I suppose. But interesting how science.
Yeah, for us, like, you know, we come from public health world or medical world, and to know that an algorithm that is created to kind of, you know, be able to detect submarines for not a very good reason, right? And that can be transformed into something that will create a lot of public good, you know, is a good thing to know, you know. So thank you.
Milind, would you like to end?
But first of all, you know, thank you to Maya, to Madhav, to be here. Really, it's such wonderful thoughts, and really very educational for everybody. We are very grateful, of course, for Aparna Hegde to be here, for the collaboration and the milestone. Hopefully, this will be the first of many other milestones that we will reach in our collaboration, but also to the other AI for social good participants in this program. It will hopefully show that this is where we want to be. This is the kind of journey that I hope we will be able to achieve with many of you. So thank you to all. And thank you, Aparna, Taneja, as well, for your wonderful hosting of this panel. I think Maya Majumdar, maybe she may have some final comments, and then we can close.
Yeah, no, I'm just so happy to have been involved with this panel. Thank you so much, Milind, for inviting me, and for all of my co-panelists for just the phenomenal stories and anecdotes. I think it's sometimes the best way to learn.
Thank you.
Thank you.
Thank you.
Also, all our co-organizers for this event from the Google Research Lab, Manoj, Divya, and all our other teammates, and also to all the team at ARMMAN. We're so grateful and excited for this milestone. And like Milind said, we hope to reach many more milestones with you and with all the other NGOs. Thank you so much.
Aparna, shall I close with just one last sentence for Aparna Hegde? And I'll say it in Hindi because I think her word. So, आपके अरमान पूरे हो ऐसी हमारी इच्छा है. So, you know.
Oh, thank you. Thank you so much. Thank you. Thank you so much. It's great to be here with you. Thank you. Thank you. Bye.
Thank you, everyone. Thank you so much.